Hello, my name is Jennifer Andrews, and today I would like to discuss the research that I found addressing obesity and health policy. Collins references the World Health Organization, which defines health policy as an agreement on health issues, goals, and objectives to be addressed, the priorities of objectives, and the main directions for achieving them. To analyze policy, he suggests using an 8-step framework to determine if the proposed policy effectively addresses important policy issues, improves the policy implementation process, and leads to better health outcomes. In implementing his analysis, policies and their anticipated outcomes can be predicted to determine the best decision. Obesity and overweight, as defined by the World Health Organization, as excessive fat accumulation constituting a health risk, represent a major public health problem affecting all age groups. Studies indicate that global obesity rates have tripled over the past 4 decades, with up to 1/3 of children in the United States classified as overweight or obese. The economic burden of obesity is equally significant. According to Ward and team, annual medical costs for adults with obesity are over $1,800 higher compared to those within healthy weight, contributing to nearly $173 billion in medical expenditures. Experts agree that the determining factor in development of obesity is an imbalance between energy consumed versus expended, with almost 40% of the total energy consumed by youth being empty calories. The prevalence of obesity is influenced by a complex interplay of biological, socioeconomic, and social factors interacting dynamically to shape dietary habits, physical activity levels, and overall health outcomes. The prevention of obesity requires prioritizing the importance of preventable risk factors for obesity. Several factors contribute to the obesity risk in children and adolescents, including the excessive consumption of energy-dense, micronutrient-poor foods such as ultra-processed foods, or UPFs. Ultra-processed foods are what many consider as comfort food, as they are designed to be highly palatable, appealing, and calorie-dense with a unique combination of enhancing taste ingredients, generating a strong rewarding stimulus. According to Calcaterra and team, modern lifestyles and patterns have moved away from culinary traditions and are characterized by frequent snacking, eating out, and poor sleep quality, which have been linked to significant increase in ultra-processed food consumption among children and adolescents. Food advertisements, food aromas, negative moods, and observing others eat can trigger the hedonic or pleasure hunger, excessive consumption of highly palatable, energy-dense foods. This issue is especially concerning in low and middle income communities and economically disadvantaged groups due to the affordability and accessibility challenges. Ultra-processed foods often serve as a primary source of nutrition, increasing malnutrition risk. So how can we fix this? We need to create environments that support healthy eating and physical activity while promoting access to healthy foods. Jalal and team conducted a systematic review and meta-analysis regarding the behavioral factors capable of influencing childhood obesity, showing that at least 60 minutes of moderate to rigorous intensity physical activity per day, or 300 minutes per week, eating breakfast every day, and eating sweets less than or equal to 3 times a week have a significant effect in reducing childhood obesity risk. Breakfast consumption and physical activity were the most powerful protective factors against excessive weight gain in children and adolescents. But how do we get after making these changes? Well, federal policies can affect the entire country. State-level policies can be tailored to address the unique needs in the state by focusing on specific societal challenges such as inadequate access to healthy foods, barriers to physical activity, and favorable or unfavorable food environments. Cleveland and his team's data analysis reviewed over 3,200 obesity prevention policies and proposed across all 50 states between 2009 and 2019. During that period, the most policies were proposed in 2011 and 2019, and overall, 18% of bills were enacted into law, with an average of 54 obesity prevention bills enacted per year. The most common topics among proposed legislation were school nutrition, followed by labeling, sales and taxes, and food assistance. The least common topics among the proposed bills were marketing and advertising to children, and physical activity and built environment. Utilizing Collins' evaluative criteria on the proposed health policies, we can predict outcomes to combat the obesity epidemic. For this research, I identified 3 areas: food assistance programs, nudge theory implementation, and school programs. The Special Supplemental Nutrition Program for Women's, Infants, and Children, also known as WIC, is a national initiative food assistance program that provides nutritional education, promotes breastfeeding, and improves access to healthcare and social services, and provides nutritious foods to low-income pregnant and postpartum individuals and their children up to age 5. Recent systematic reviews demonstrated that WIC food packages improve fruit and vegetable consumption at the national and state levels. This gives young families access to healthy food choices and healthy start establishing long life choices and patterns, protecting them from nutritional risks associated with poverty. Although these programs play a vital role in improving inequities and health outcomes, their impact is limited to low-income populations rather than broader U.S. populations. Preventative strategies that can potentially reach the whole population regardless of economic status could be more feasible. Causes of obesity are complex and deeply rooted. Early efforts to address obesity have focused on behavioral change rather than addressing structural or economic factors, placing the responsibility to engage in health-promoting activities on the individual. Overall, these interventions didn't work, or at least didn't sustain long-term weight management. Take, for example, the nudge theory strategy. This was a collection of ideas by Thaler and Sistine in 2008 that introduced the concept of choice architecture, which encompasses external influences that subtly steer individuals' decisions in a particular direction. For example, items that are placed at eye level in a supermarket may be selected more frequently than those away from eye level. With the nudge approach, they aim to create strong governmental oversight without restrictive regulations. Unfortunately, modifying the environment while preserving freedom of choice without limiting individual choices or affecting their finances may not be sufficient to drive significant long-term behavior changes in obesity prevention. For example, voluntary industry policies have largely been ineffective in reducing excess sugar consumption, leading governments worldwide to increase and implement taxes on sugar-sweetened beverages, also known as sugar tax. With children spending a great deal of time in the academic setting, the school environment plays a crucial role in shaping young people's eating habits and preferences as future consumers. To impede the progress of childhood and adolescent obesity, school environments are vital in preventing adolescent obesity and has been described as an ideal convergence point for teachers, parents, and other stakeholders to develop and implement lifestyle, behavioral, and nutrition interventions like promoting physical activity and healthy eating. This is why I believe this is the best choice to implement lasting change. Global variations in childhood obesity rates underscore the intricate relationship between public health policy and lifestyle influences across different countries. Like the United States, Japan is a highly industrialized and urbanized nation, yet it maintains one of the lowest childhood obesity rates in the world at 4.5%. Japan's success is accredited to a unified approach that combines prevention-oriented policies with dietary traditions centered on moderation and variety. In contrast, the United States childhood obesity rate exceeds 20%, driven by systemic inequities, increased availability of calorie-dense foods, and insufficient opportunities for physical activity. Japanese schools play a vital role in this framework by incorporating the Shikoiku School Lunch Act into their curricula. The basic law on Shikoiku, which is the food and nutrition education, was enacted in 2005 and revised with the School Lunch Act in 2008, requiring school meals to adhere to a strict nutritional standard and incorporate fresh, locally sourced ingredients. Japanese schools prepare meals in-house, ensuring high-quality nutrition, unlike outsourcing practices seen in other countries like the United States. Tanaka and Miyoshi discussed the decline in the number of children skipping breakfast and overall improvement in their quality of life, highlighting Japan's school lunch program's vital role in fostering future healthy minds and bodies. As previously mentioned, physical activity is a key determinant of childhood obesity. U.S. children's lifestyles are increasingly characterized by sedentary behavior influenced by technological advancements, cultural norms, and urban designs that often restrict safe and practical opportunities for physical activity. Additionally, schools play a pivotal role in reinforcing physical activity through mandatory physical education programs. Japanese schools reach beyond the traditional PE classes, incorporating physical activity into daily routines like the Regio Taiso, radiocalisthenics involving exercises at the beginning of school. They also host extracurricular sport programs and events like sports days, which foster a shared sense of responsibility and of health and well-being. While U.S. schools are required to include physical activity in their curriculum, the quality, duration, and frequency of PE programs created by policies vary by school district, complicating efforts to promote children's active lifestyles. Programs face challenges such as funding constraints and socioeconomic disparities. Funding and research disparities lead to inconsistent implementation, with low-income families often facing financial obstacles for equipment costs or transportation challenges, limiting access to fitness challenges. Michelle Obama's Let's Move campaign sought to combat childhood obesity by enhancing meal standards and opportunities for physical activity in schools. While the campaign spurred policy and practice changes, its long-term impact remains debatable due to inconsistent implementation, inadequate funding, and limited follow-through. This highlights the need for a multi-level approach in ensuring sustained efforts to address this epidemic. Several U.S. state policies have demonstrated efficacy in improving health by targeting school strategies. In 2024, the USDA released the final rule on all foods sold in schools required by the Healthy Hunger-Free Kids Act of 2010, mandating stricter nutritional standards for school foods. Farmington Public Schools in Minnesota, serving over 6,700 students across 8 schools, implemented a local wellness policy aimed at strengthening nutrition program and improving health standards for school meals. The district's food service department contracted with local farms, increasing healthy options in vending machines and the cafeteria, and created a healthy snack shop for students. For this policy to work, the U.S. needs to align to a cohesive national wellness strategy, coordinating efforts across federal, state, and local levels to enhance program consistency and equity. The Japanese government funds schools, facilities, and staff, while families pay for the ingredients, averaging 4,000 yen monthly per child. This model could be feasibly adapted in the United States as preventing obesity through public education, leading to significant savings in medical costs. Strong competitive food policies in schools are associated with lower rates of childhood obesity. This could be considered the selling point that could establish it as a priority issue for advocacy and health policy development. Therefore, efforts to eliminate ultra-processed foods and sugar-sweetened beverages from meals and vending machines, and even fundraisers in schools, and increasing access to healthier foods and beverages choices are key. In addition, updating menus to develop nutritious, well-balanced, and appealing meal plans are vital to success. Finally, policymakers should prioritize investing in school infrastructures, such as playgrounds and sports facilities, to ensure equitable access to physical activity for children of all socioeconomic backgrounds. Addressing barriers to obesity management is essential before there is hope to improve this epidemic. In researching and comparing these 3 potential health policies and their anticipated outcomes, policies that focus on school programs to address the obesity epidemic represent the most effective choice. If we continue to prioritize policies like these, there may be hope in the future. My information and research would not be possible without the brilliant minds behind the authors of these various sources, whose research is truly making a difference on getting to the issues behind obesity. With their help and many others, we can find solutions to this issue. Thank you for taking the time to listen to my presentation.